Hello, everybody. Welcome. We'll get started in just a couple minutes, just giving some time for people to come in and get settled. If people want to start by sharing where they're from, organization and role, that would be helpful so for us to get a sense of who's here today. Cool. Hi, welcome, Brandy, Angela, Candace. All right, well, as people continue to enter our session, I'm gonna start with some housekeeping stuff. So welcome to today's MTAC session entitled Minds Matter, Strategies for Supporting Students with Mental Health Challenges in Schools. We are so happy you're taking time out of your busy schedules to join us today. Before we get started, we have a few housekeeping items to go over with you. We would love for you to learn more about you in the chat box. Take a minute to enter your organization, role, and where you are located. As part of our session, we must provide you with this disclaimer. This presentation was prepared by NTAC under a cooperative agreement from HHS. While this event is supported by HHS, the contents are those of the authors and do not necessarily represent the official views of HHS or the US government. While we hope that there are not any security issues that happen today, in the event that any may occur, the session will immediately end and you will be notified by email how to rejoin a new session. Thank you again for attending one of our NTAC sessions. Listed here are all of our incredible national partners that have come together to utilize their expertise and their subject matter knowledge to help inform the field by creating products, resources, and sessions like this one to enhance the behavioral and mental health fields. Before we get started, we want to address some commonly asked questions. In the follow-up email for today's session, you will receive a certificate of completion, a link to the recording of the session, and a copy of the slide deck presentation that's being shown. You should also have received a copy of the slide deck in the reminder email that was sent either earlier today or yesterday, if you would like to access it for today's session. All right, now we have made it through our housekeeping items. So welcome again to today's session, Minds Matter, Strategies for Supporting Students with Mental Health Challenges in School. This is the last part of our multi-part learning community series for educators. And our topic today will be intellectual and developmental disabilities. Our presenters today are myself and Ms. Mary Neapolitan Gustafson. I really hope I pronounced that right. I am a child and adolescent psychiatrist with MedStar Georgetown University Hospital in Washington, D.C. I do work in our outpatient clinic with early and first episode psychosis patients. I also run an adolescent intensive outpatient program through MedStar Georgetown, and I work in collaboration with the MedStar Center for Wellbeing in School Environments, or WISE, to bring psychiatry services to schools in DC. And before I went to medical school to become a doctor, I was a middle school teacher with DC Public Schools, so I have some of that experience as well. And now I'll pass it off to Mary to introduce herself.
Hi, I am Mary Neapolitan Gustafson. I know that one's a mouthful. You did great. Thank you. I am a BCBA in the Northeast Florida area, predominantly Jacksonville area. I'm the program director of behavior services for a local non-for-profit. And I do provide part-time services, like direct services to individuals in the community, as well as teach some basic intro to applied behavioral analysis classes to direct care staff. And I would say my area of expertise or specialty is in severe maladaptive behaviors like physical aggression, property destruction, inappropriate sexual behaviors. And that's who I am. Hello, thanks for having me.
Thank you for being here. We're so excited to have everyone here today. All right. So we're going to start out today with a quick mood check-in, see where everyone's at on this Friday morning or afternoon, depending on where you're located. We'll talk about what IDD is and the definition, and kind of compare it to developmental disabilities, and maybe talk a little bit about some statistics around IDD. And then we'll move into talking about IDD in transition age youth and how to manage that transition from school to the real world. And then as we go through these definitions and ideas around supports for these young people, have in mind or try to bring to mind somebody who you've worked with or who you're currently working with who maybe is challenging and could be helpful to talk about in our group today. Getting perspectives, not just from Mary and I, but also from everyone in this group, can be really helpful in terms of managing some of these really challenging cases. All right, so to get started, how's everyone feeling today? Pick one or more emojis and put them in the chat so we can see how people are doing today. Oh, good, a happy face, nice. Yeah, it's I feel like last week felt like such a long week and people were all kind of feeling that, and this week it seems like a little bit, I don't know, it was a little lighter for some reason. Maybe just getting into spring feels good. Cool. Well, thanks everyone for just taking a mindful moment to check in with yourself and to let us know where you are. Okay. So let's talk a little bit about intellectual developmental disorder. IDD, intellectual developmental disorder, and ID, intellectual disability, are interchangeable. They mean the same thing. So I may use them interchangeably as I'm talking. Just know that they have the same definition. I first just want to show you how large the category of neurodevelopmental disorders is. And IDD is just one of them. It's a group of disorders that's defined by some sort of condition that affects the development of the nervous system. So that includes the brain and also the spinal cord. And it interferes with functioning in terms of like the acquisition, retention, or application of specific skills. And that can lead to difficulties in social, cognitive, and emotional functioning. So there's delays or disturbances, but it could be in a wide variety of developmental domains. And as you can see here, that includes cognitive domains, language domains, social and emotional domains, learning and motor disorders. So it's really like it's a large category. And we're only going to be focusing on a very small part of that today. So what is IDD? Intellectual disability starts during the developmental period. So that's like in the period of time when like less than 18 is really how most people define it. And it's categorized by differences in two specific categories. One is intellectual functioning or intelligence, and that includes the ability to learn, reason, problem solve, and then also adaptive behaviors. So those are things like everyday social skills and life skills. Intellectual abilities are usually measured with cognitive testing, like for example, an IQ test. And then the severity of the intellectual disability is determined by the adaptive score. So that can be mild, moderate, severe, or profound. And that includes like activities of daily living, things like being able to dress yourself, maintain personal hygiene, feed yourself, communicate, things like that. About 1% of the population has an IDD diagnosis. And of those, that 1%, about 85% of those kids are considered mild IDD. So just to get a sense of like the prevalence in the population. When we're thinking about schools, intellectual disability is defined pretty similarly as the definition I just gave you is from the Diagnostic and Statistical Manual that psychiatrists use to diagnose intellectual disability, but a little bit different. This is from the Individuals with Disabilities in Education Act, which kind of defines how we create individualized plans for kids in school. And it defines intellectual disability as significantly sub-average general intellectual functioning, existing concurrently with deficits in adaptive behavior and manifested during the developmental period that adversely affects a child's educational performance. So I think the key difference here is that we're really looking at educational performance. For kids with IDD, there is a much higher risk to have other comorbid disorders, things like problem behaviors, affective disorders like depression and bipolar disorder, autism spectrum disorder, psychotic disorders, and anxiety disorders. And sometimes, or not sometimes, a lot of times, these comorbid disorders are pretty difficult to diagnose because the assessment is different. We may not be able to ask the same kinds of questions and expect the same types of responses that we would get from kids who do not have IDD. And so we kind of have to adjust the assessment to make sure that we're really doing a thorough job at identifying comorbidities. So I'll point out the existence of the DMID, which is a companion manual to the DSM, and it's specifically designed to create diagnostic criteria to diagnose mental health conditions for people with IDD. So it can be really helpful to reference. Okay. Now I'm gonna pass it off to Mary to talk a little bit about treatments and supports.
Thanks. So our treatments and supports are going to vary differently, obviously, because like you mentioned, there's such a huge range of need. I will say that a lot of my experience happens to be in that little section of people with more of the severe. But I do work with a lot of dually diagnosed individuals too. So my experience may not exactly be matching the relevance, right, with that 85% having mild, but I do tend to work with the harder cases, so I guess would match. So you mentioned that the services under IDEA, right? And that might come or should come with that IEP, right? So in the schools, we're going to have access to all sorts of treatments and services within that kind of umbrella under the school. That's going to be right? Required to be offered under the public school program anyway. Obviously, there can be different types of schools too, but can you go to the next slide? Sorry. So predominantly that transition is going to start around 18, right? So I will say I'm in the state of Florida, so things might be different, but the IDEA and IEPs are nationwide. So even if Florida does it a little bit differently, I would hope that it is similar across the states. But so once a student turns 18, they typically will graduate, do their finishing up their academic sections of schools, but we are typically able, and it actually differs county to county, so I'm sure those things are similar among states, but students can stay in the public school system until, like I said, some counties it's their 22nd birthday, some counties it's through their 22nd school year, where they kind of start changing to functional skills. So working instead of writing and reading and academics, it might be more related to a job program or daily living skills even. Can you go to the next slide also? So I did briefly mention, and I really want to emphasize, right, how an individual or a child with IDD might have so many supports and services, not just a mental health provider, but we'll talk about those in a second, but they are often all under one umbrella. You might even get a provider that can help collaborate with parents and maybe even provide some home support too. But the big thing and the big challenge is what happens after that. So I love that schools are starting to do more of that transition. It really is critical to our students' development, but things are going to change majorly, and that's what we hope to help support. So parents may not think about like the funding for each single one of those little PT, OT, mental health service, transportation, and they're all under one umbrella. So those things are going to get complicated as adult life does for all of us, I suppose. You can go on. If you do the next one, there you go. So certainly not all of those supports might look like this, just for one individual. I guess from my experience, one of the biggest challenges for families and their students is that the number of supports and services, like the time, is going to just change so much. So you might have a student that has, physical therapy twice a week, occupational therapy also 3 days a week, speech every day. They have a behavior analyst that they work with regularly. And then all of a sudden they turn 22 and you're like, how do we do this? Hold on, wait, I get how many hours? I went from having, 20 hours of behavioral support at home to now having an hour a week. And this is definitely the reality. And I will say Florida is not famous for having the most funding, but I would imagine that these things are very similar state to state, even if the adult services do get funded a little bit more. So do another slide there. Right, what are we focusing on? How are we teaching these students? And what does that look like for while we're in school? What kind of thought processes, right, and programs can we help prepare them? So lots of collaboration meetings, right? Even those IEP meetings kind of turn into what you might call a transition meeting, or in addition to your IEP meetings. There might be conversations. This is one that I have with families so often, and they're like, but my student has a one-on-one in school and they need that. Unfortunately, the funding for that as an adult, I can almost promise, is very rarely going to be there. And most of these, when we talk about the number of supports and services that these students need, there's not many families that I know that can private pay for all of those, right? So we're relying on other funding sources, and then we're bound to their criteria. And unfortunately, the school system, and so I work under a Medicaid waiver program, primarily Medicaid and Medicaid waiver services. They have very different rules, very different expectations, and the criteria to get a one-on-one in school doesn't look like that when they magically turn 22. There's all of a sudden no changes. So, or I mean, lots of changes. So what's that going to look like, right? Hopefully we're preparing that student that those final few years that we are starting to fade that one-on-one, right? We're maybe moving to more of a 1-to-3 situation, carefully, slowly preparing them for that. And that's going to apply to, I feel like from my experience, the supervision is one it shocks families. They're like, what do you mean? He's not going to survive without his companion. He needs the one-on-one. But they're definitely, I have seen so many success stories too, which is fantastic. Just talking about those, I think is typical for us, right? We're used to that, but actually preparing the students for that change. From my experience, especially this population needs lots of preparation, right? Like having those conversations every week for their last 2 years of the public school system, right? We're going to be riding a different bus when we become an adult. We're going to be going to a different place. Our routine's going to change. We might wake up at a different time in the morning. We might not have breakfast at school anymore, right? Like there's all of those little changes that can be adult or can be challenging for, our neurotypical population, could be so much more challenging for a kid with IDD. So I do always encourage families to not just talk about it, but show them, go to programs, start going once a month to a different day program around town if you think that's what your son or daughter or whoever may be interested in. A lot of families don't know what those programs look like. And I tell them all the time, I'm in a larger metro area of Jacksonville. There are tons of different programs, and there's a ton of great programs, but they're not all right for every student, so really finding ones that can provide the social interactions, the continued learning, right? The job opportunities and things like that for your specific student is going to be really challenging unless you're actually putting in that time and checking out all the different places that your community has to offer. Another thing that I really encourage parents, guardians to, well, hopefully they'll be guardians to do, and I do know that this is different in state to state also, but in the state of Florida, when our individuals with IDD turn 18, they are immediately considered a competent adult. So that can present really big challenges, especially with all of, there's often a lot of health concerns. And so I really encourage families to go through that process before their child turns 18, and also to familiarize themselves with that Bill of Rights. To start, there's going to be a lot of education, right? Like our state requires all of our providers to be educating our students on that, but for parents and families to familiarize yourself also, and teachers, and all the providers, right? Because an adult with IDD has all of the rights that we do, but also this list that's very specific, that's going to be a big, it's going to affect their life greatly, especially when our population is one of the most highest instances of abuse through most high care need, right, services and sports. So some of the goals that I usually talk about or encourage for that transition aren't just what do we want to do, but what skills do we need for employability, right? Is that the path that your student is taking? And what does that look like? What kind of jobs do they enjoy? What kind of jobs are they going to excel at? There's so many opportunities in our community, right? I've heard so many instances. Like I know of a guy who his family helped him get a bike with a billboard, and he gets paid to advertise, and he rides his bike up and down local areas, and it's like, that's what a great creative job. So there might depending on your student, there might be different levels of creativity that we work towards for employability, but to start thinking of that when they're young. Social skills, right? How are our learners going to create friends and develop relationships? What will that look like for them when they're not in a classroom with the same students, maybe for 4, 5, 6 years? How do they navigate the community? Do they know how to ride the bus? Do they know how to call an Uber? Is that safe for them? In the Jacksonville area, there's something called the JTA Connect, which is a really great service. I believe it's like $3 a ride, and you can arrange it to come pick you up at a certain time. It's with a trained and safe provider and a small setting. So it's kind of like a sister to the bus, transportation services in the area. Do they know what to do if they are at Walmart and the bus is late, right? Like there's so many challenges navigating the community for all of us, especially if our student doesn't read or doesn't know how to ask for help. The living choices, right? What do they want? What do their families and supports think is going to be the jumping off point to live independently, right? I say that because it might not be forever. There might be small steps in that way or down that path, right? Of needing more help and eventually transitioning to more independent living. Do they know how to make life choices? How are they going to manage problematic situations, right? Like a lot of the learners that I've worked with are, they do amazing trainings and they can complete job tasks according to, follow the steps. But what happens when that pattern's broken? What happens when there's a problem out of left field and the power goes out and you're like, but I have to complete things in the step, right? Do we plan and train for those type of changes? And safety skills that could range hugely, right? Depending on your students' needs, but do they know do they know who trusted people are? Do they know how to advocate for themselves in an unsafe situation? Do they know how to do something as simple as call 911? And if they don't have the dexterity to, what's a workaround for that for them, right? There's lots of creativity, I think, in this transition support that we can provide. Go to the next one. Thanks. So once we're over to the adult world, it's going to take a lot more coordination, right? Their goals are hopefully still person-centered, just like with that IEP in school. But instead of the school facilitating a lot of that, you might have the parents doing it. You might have a guardian doing it. They might be doing it themselves. Hopefully, they have, if they are doing it themselves, or there's, and I would hope parents have that too, a case manager of sorts. Under the program that I work, they're called waiver support coordinators, who's going to help advocate for more funds if it's needed, making sure that they're happy, making sure that those choices that they've made as an adult now are going to be suitable to their needs. And then do they have access? So that some of those adult services might look like daytime activities, right? So a meaningful day activity. A lot of the individuals that I work with go to a day program, but there's so many different ones. There could be ones that are more focused on social skills. There may be ones that are more focused on work skills. There may be ones more focused on healthcare needs, meaning like physical health needs. There's different levels of supported employment. So that being where you may get someone called a job coach or something like that, that is able to sort of follow along, provide additional training, who has training working with someone with IDD and can really be a support beyond what an employer would be able to provide. It might even start with like ground one, we're just gonna work on writing an answer on a resume, and that hopefully grow into helping us get a job and following along and then fading out that service as they succeed. Different living arrangements. So I I am always amazed, especially like the school age families that I work with, that they are so focused on the supports and services that their child is getting as a youth, that they don't even realize that the options that there are for living choices. It could be an additional staff within your home to make sure that they are happy and well cared for while you go to work, or just to be able to have a break to go to the grocery store, or living in group homes, or other types of supported living environments. So it might look like an individual could rent a room in a house, just, like you might find a couple roommates and have a place of your own. But also they may have support staff that comes in every morning for 2 hours and every evening for 4 hours, so they make sure that their dinner is cooked safely, and that they take their medications, and that they can get to the store. Or maybe they can just have help using the telephone to make sure that they talk to their friends, right? And have that type of respite support or personal support. It might look like there's a lot of different levels within that group home world. That minimal, basic, moderate, or behavior focused, intensive behavior focused. In Florida, a few years ago, they even opened I believe it's EIB, so extensive intensive behavior focused. It's for really challenging situations, to essentially avoid that institutional type setting. So hopefully can help your family member live even with super challenging behaviors, with the appropriate level of support and care in a regular house, in a regular community, being able to have opportunities to do regular things on the weekends, right? Transportation can be such a challenging one that may not get as much attention, right? The school bus system is something that I feel like people take for granted. And then you get to be an adult and you're like, well, we've got great services. We've got a great place to go all day. He's got a social group that he goes to on Saturday, but how do we get there, right? So that even a separate provider that might be able to pick you up and drive you across town reliably, right? And get you to your job in time, get you to your social group in time, get you to your doctor's appointment. So, um, you, how do we bring that all together? What are we teaching our students? And I mentioned earlier, probably not just talking to them about the options, but something, and as a behavior analyst, skills training is, something obviously that I focus on, right? But how do we ensure that they can't just answer not only can they answer the questions correctly, but actually model that behavior? How have we tried enough scenarios and put them in enough situations that not only can they tell you how to ride the bus, but we've seen that they ride the bus, and then given them opportunities, let's just say they're going to do it on their own, that we let them do it on their own before they're fully invested in this adult life. Um, um, do we know that they have the resources in place? So in my state, the wait list to get in the waiver program is sometimes years and years long. It's not something that you can just hope for once they turn 18, 20, 21, 22, that we can apply and it'll be great and we'll have it all lined up. I know families that have put their students or children on the wait list when they were 12 and they're still waiting when they're 24. So it can be really, really challenging. And obviously that weight can change on their level of crisis or their level of need. But for a low crisis situation, it can be really hard. I unfortunately know many families that talk about, how excited they are to finally be able to get funds for those supports and services. And because their student or their child has been at home for 4 years and they've graduated years ago, and now they are suffering from additional mental health problems like depression because they haven't had opportunities to continue to use all those skills that the schools did help them to provide. So the sooner we start having those conversations and working together with all of the supports and services, the more successful our students are going to be in the real world and out there as an adult.
Okay. Thank you so much. That was really useful. I'm going to stop sharing. If people could turn their cameras on, I think that would be good so we can kind of see faces of people who are here. And then ask any questions that came up or comments or things that would be helpful to talk about now that we've kind of given you a very brief overview of a pretty complex topic. One thing that came up for me, Mary, while you were talking was this, I think you briefly mentioned this idea of guardianship for like parents and caregivers to consider. How do you usually advise families around that, around guardianship?
I think it's going to depend on the individual, and like I said, I do tend to work with people with higher need of support. So I just like to give them the information because it often does involve a lawyer or supports. I know in my area, sometimes I refer them. There's one organization that has grants and things to help that at minimal cost to families. But and this is definitely not my area of expertise. I usually am just like, I hope that this is something you're aware of and I can help you get more, I'll lead you in the right direction. But so, there's like a planetary guardian that has total guardianship, or a guardian advocate, I feel like is a little more common, where that, and it's not necessarily a parent, but right, that person in your life has been legally established as someone to help you make healthcare, financial type decisions. And that can obviously depend, there can be very specific or very broad depending on the person too. But and not everybody, is going to need that. I certainly work with individuals who don't have that and are doing great, as a competent adult. But there are definitely times, especially like I said, with the severe behavior that I work with, or more of a severe level of IDD that really need that. It is actually the state of Florida is coming out with a new level of advocacy. It's sort of, I can't remember the official name of it, but it's essentially an advocate program where someone with IDD can say, and it's official, that like, I want Mary to be my advocate. And there's no legal standing there, but it's sort of an official helper, right? That like, this person knows me, I trust them, and I want them to participate in my decisions, even though it's ultimately still that individual's decision. So there's a lot of different levels of that support from my knowledge. And like I said, I'm usually more of one to refer them to those people that are experts in that.
Awesome, thank you. Any other questions that come up for people? What about cases? Is anyone working with a student who they're struggling to find support for in this transition? One thing that I've noticed as a psychiatrist is that the people who I see who have ID also have some sort of comorbid mental health diagnosis. Like for me in particular, it's usually bipolar disorder or schizophrenia, but I know also like anxiety disorders and depressive disorders are common. I have found that that can make it more difficult to find a place that will accept them, like a day program or something like that, or services that are willing to work with them, even if the mental health condition is well managed. Have you encountered anything like that, Mary, or anyone?
Absolutely.
How did it?
Absolutely. I mean, even just a recent scenario, a young lady was moving into a group home, and this is a behavior focused group home who knows what they're doing and does it well. But there's a dual diagnosis, and it just really, it scared all the staff. And they, every one of them at one point has asked me, like, but how are we going to manage this? And it's like, you guys are great. You're going to work closely with the psychiatrist and their team, and you're going to get to know this person just like anyone else, and you're going to help manage it just as if they had diabetes or whatever other you know support they need, and it's going to be fine. I do always encourage them to get and gather as much information about it as they can, right, to help educate themselves. So yeah, I think it's especially challenging. I personally, well, something like schizophrenia and bipolar disorder have their own difficulties, but depression, I think, or anxiety, especially if you have someone with IDD, autism, and depression, right? It's like staff that I work with might say, but like, is this depression or is this autism? And how do we manage these differently with somebody who doesn't communicate verbally? And there's just such a multitude of challenges all together that it's like, where do we start? How do we know what's what? How do we know that somebody with IDD and clinical depression that already needs help showering, for example, but now they're struggling even more, right? It's like, is this a behavioral issue that you can help with, or is this clinical depression, right? Like, are they struggling with their ADLs even more because they're experiencing depression, but they don't have the verbal ability to tell you? So those do become even more challenging. Yeah. And really we, as behavior analysts, and not just our like care team too, within the agency I work with, are really encouraged to work with our psychiatrists closely, have those conversations. And I am super grateful that we don't have psychiatrists that work with our agency, but in fact, I have an appointment next week where she's great, and she makes a separate appointment for the son, and then I go with mom, and just me and mom and psychiatrist will sit and talk about observations and changes in their life. And so that the psychiatrist, like I said, has a separate appointment even with that individual, so that it's because it's not always easy to talk about those things. He isn't very patient, let's just say. So it takes a lot of collaboration, a lot of teamwork.
Yeah, I think that actually highlights something that's so important is like with these kids, like you often have like a really large team of people supporting them, and being in communication with all of the people on the team is so important so that there aren't mixed messages or conflicting approaches or, things that could potentially be, harmful, honestly, to the child.
Yeah.
Really important. That your story actually reminds me of this kid we recently saw who is nonverbal autism ID and was having like worsening behaviors of like, moving objects. So it's just like really rigid behaviors. And they were wondering if this could potentially be OCD. And with having the BCBA be part of the evaluation, it became like more clear that yeah, this probably is OCD, but it was really like their input that was super helpful in clarifying what that could be. And with treatment, with medication for OCD, and then like continuing the ABA, they've really been able to do better. So yeah, collaborating with the team is so important.
Absolutely. It's I actually I know someone that recently got a diagnosis and it has seen the psychiatrist for a very long time. You know, they have a really good relationship and they know each other really well. But the data that I was starting to collect on repetitive statements, so this individual does have IDD and autism. So, right, repetitive type of statements and a narrowed focus on, topics is commonly we're thinking autism, right? But the obsession about the numbers and the compulsion with counting the number of activities, the specific thing that he was doing, it took his psychiatric treatment in a whole different direction that has really helped him. And it's just interesting, right? Even for somebody, and they've probably worked together for 10 years, better part of 10 years. So it's right, and that's exactly what we've been able to do, right? And um, with medication and ABA and the whole team on board, which is easier said than done sometimes, he's been able to have a much more successful year.
That's awesome.
Yeah.
It reminds me, I didn't have a slide on this, which I typically do on like treatment. And I didn't have the slide because the treatment is like all of the supports that you presented, right? There's no medication that would treat ID or IDD. But because there's often comorbidities, like mood disorders or OCD or psychosis, things like that, we would want to be treating those things with medication if needed or if therapy isn't helpful. And then in the rare cases where there is like severe aggression, safety concerns related to behaviors, Abilify, generic name is aripiprazole, or risperidone or Risperdal, are the two FDA-approved medications for people with developmental disabilities and like irritability aggression. But it would always be the goal to use those medications short-term while engaging in therapy and then to hopefully eventually be able to taper them off.
And that's luckily one of those things too that like our funding, right? We aren't intended to be forever either, right? Hopefully we can teach skills that they can take with them and generalize in other settings. But one of the things I'm really grateful for, right? And when I do present cases to the state for approval, they have us list what meds they're on, right? And clearly this individual is doing well right now on the, Abilify, let's just say, that they will not fade our services until those medications related to behavior that are just provided for behavior have been reduced as much as possible, and that we still are problem behavior free. So that's even at that state level, it's really nice to see that they understand, right? Then they're not going to just say, well, Johnny's doing great, so Mary, we don't need you anymore, and take it away, doctor. And you're like, wait, we need to see how they do without these things first, right? So, and it's really nice.
That is nice, yeah. Another question that I have is about the IEP. When we get to the point of it being like, between 18 and 22, when like the services offered by the school are ending, does the IEP ever translate to a different setting, or is it like written to be used as a template for services, or how can you use that to kind of advocate for what a student may need?
So that can be challenging. And right, like I do only work in one sector, right? Like I work in the Medicaid waiver typically. So it's sort of the backup of backups of funding, but they will and do encourage collaboration with the school, like for that IEP meeting or for those transition meetings. But we really don't have a lot of opportunities to work with our students in the school setting, right? Because of the IDEA, right? And then it's like, well, that should be funded by this under this umbrella. Like you're an outside umbrella. And hopefully we get a little opportunity to work together, but there isn't as much as I would like. But so that IEP does not come with them. It is something that families a lot of times will share with me so that I at least know what we have been doing. I usually try to meet with teachers, but those skills it doesn't necessarily translate over, right? So you're sort of at a whole new ball game. I did have one guy who he's been one of those that's just made an amazing transition, and I'm so grateful for his whole team. But he was one who moved in to one of our group homes, a behavior focused group home, really young, as a teenager, and was extremely aggressive and was really challenging case. And he was had one-on-one at school, had awesome teachers. They really were happy. They reached out to me even when they weren't expected to collaborate. And like I said, had a great team. But he we were really worried how these things are going to work after school. He attended what we call like a center school. So I don't know that they even have these all over Florida, but in the Jacksonville area, there's a school that is exclusively for IDD. So everyone at the entire school has IDD, and it's like they have all of the supports and services. It's like this is everybody's specialty instead of just a classroom or a wing of a school. So they have all of the stuff that he needs, right? They're really able to support him well in that setting. But what's that going to look like in a day program setting? So, and that's not funded, right? Those transition supports, there's no funding for it. So I encouraged anytime he was out of school, and he would go to summer programs and stuff like that too, even if it was just one day, the teacher planning day, that he would come to our day program. And granted, he could have chosen to go to any program in the community, but his family wanted him to come to ours. So even if it was just for an afternoon, even for an hour, that I could hang out with him in the lunchroom, to be able to see this environment. And because his aggression was so severe, everybody's like, oh, how's this going to work, right? And he had I guess it was a bit of a happy accident after the pandemic. It was really a struggle even in the schools. And, having him worry about coming back to in-person school, how's this going to work? We were able to fade his 1-to-1 to a 1-to-3 while he was still in school and start these tiny little trickles of attending a different program, seeing what it looks like, adding to he uses a Proloquo to go app to communicate, adding in, here's the van, this is what that's going to look like. Every single week we would have a conversation about what this is going to be like after you're finished in school. It felt like a long process, right? We were really probably doing this for the better part of 3 years. But happy to say he comes to our program every day and does great and loves it and has friends and is doing things that we never thought he would do. So, it really is possible. It just takes extra. It takes extra planning, extra collaboration, extra resources. And there were some times that our program would say, we don't have the capacity to do that today. And it's like, all right, next month we're going to go for it again, So it's just one of those things that you've got to keep doing. We can't just have a collaboration meeting and call it well, we've done our transition support. It's a process.
Yeah, definitely. And it sounds like the sooner you can start that planning, the better.
Absolutely. Absolutely.
All right. If anyone else has a question, I'll open it up now. Otherwise we can go back to our closing slides. Okay, we've got a quiet group today. That's okay. Let's present this slide. Okay. Well, thank you everyone again for being here today. Again, to address some of these commonly asked questions, in the follow-up email that you get for today's session, you'll get a certificate of completion, a link to the recording of the session, and a copy of the slide deck of the presentation that you saw today. You should have also received a copy of the slide deck in the reminder email for this session. Also, your feedback is really important to us. We need to hear from you in order to keep bringing you these free resources. There's a survey that you will receive after the session ends. It's an important part of our quality control and to future funding of this project that allows us to continue to provide you with resources and training at no cost. In addition, it allows us to continually improve our services and provide the information and resources that you are needing in the field. So please take a few minutes to let us know your thoughts. It would be greatly appreciated. There's 3 ways to access the survey. The link will be put into the chat box. It will automatically pop up in your browser when the webinar ends, and it will also be provided in the follow-up email sent after the session. So please take the survey. We welcome you to access our website to see upcoming events, archived recordings, request support, see our publications and other resources, and sign up for our newsletter. We're also on social media, so you're welcome to follow us on Facebook, Instagram, X, LinkedIn. And then here's our contact information. Our email address, phone number, website, and flyers. So again, feel free to access those things as well. And thank you so much. I hope everyone has a wonderful weekend. And that we see you around NTAC again in the future.